Our first presenter is Dr. Ron Wald. He will discuss transitions from CRRT to intermittent renal replacement therapy. Ron?
Thank you so much for the introduction, and thank you to Ravi and the organizing committee for inviting me. So I'll be talking about a dilemma that comes up in clinical care that I think doesn't have a lot of evidence behind it, so I will permit myself some scientific license to talk about how I would approach this problem of transitions. These are my disclosures. And to start off with a vignette to set the stage, a 70-year-old woman with severe pneumonia complicated by AKI. She started on CRRT, which she receives for 5 days. On day 5, her fluid balance is positive 6 liters. She's net negative by 1 liter over the past few days, but she's still oligoanuric, mechanically ventilated on pressors, although in fairness, her pressor burden has come down somewhat from a previous peak. So the ICU team asks you, could you consider switching her over to intermittent hemodialysis? And so the question is, what would you do? So the objectives for today are as follows. We're going to define what constitutes a successful modality transition, identify risk factors for an unsuccessful transition, and propose a framework for modality transitions. What do the KDIGO guidelines say about modality transitions? They say, first of all, in terms of modality choice, that we should use CRRT rather than standard intermittent renal replacement therapy for hemodynamically unstable patients. And that's something we generally accept. But on the topic of transitioning, they're a little more broad or vague. They say once hemodynamic stability is achieved, and by the way, how you define hemodynamic stability, treatment may be switched to standard intermittent hemodialysis. As far as I know, the only trial in the field of acute renal replacement therapy to give some standards or protocolization around transitions was the ATN trial, with which we're all familiar. And essentially, they give us some guidance based on the burden of pressors the patient was receiving, the so-called SOFA cardiovascular score. Essentially, a score of 3 or 4 implies that the patient is receiving norepinephrine at some dose. And for those patients, the recommendation was to initiate CRRT or SLED. And for those with SOFA scores between 0 and 2, intermittent hemodialysis was considered acceptable. But over time, as patients hopefully stabilize, if the CV SOFA score remained low in the 0 to 1 range for 24 hours, it was okay to switch to intermittent hemodialysis. But if the patient remained on any vasoactive medication, they recommended, in fact, protocolized that the patient had to remain on CRRT or SLED. In the START-AKI trial, which we aimed deliberately to be very pragmatic, we gave some broad recommendations about modality. We said that for patients receiving SLED or CRRT, a modality switch to IHD was reasonable if the patient has been off all continuous infusions of vasopressors and inotropes for the preceding 12 hours. But again, clinicians had general discretion to do what they wanted to. So what constitutes a successful transition? Number one, we want to hope that when a patient transfers from continuous to intermittent therapy, that the objectives of renal replacement therapy remain fulfilled, namely fluid balance management is adequate, solute control is good with good acid-base homeostasis achieved, and electrolyte control. That goes without saying. But we also want to minimize iatrogenic events, in particular interdialytic hypotension. We want to ensure that medication dose and the appropriate medication dose and frequency are appropriately adjusted. We also want to ensure that the transition will facilitate patient in their journey through their critical illness, facilitate rehabilitation, and hopefully transfer out of the ICU. And finally, the transition has to be consistent with available hospital resources. At my hospital, we're always short of hemodialysis nurses, and so you have to think very carefully before switching someone to IHD that nurses will be available to perform it in the context of all the other things they need to do. And finally, we want to make sure that the transition from CRRT to IHD will not compromise patient or kidney survival. So what do we know in the literature about the success of transitions? And I'll tell you right away, there are not many papers written on this topic. And the 2 that have been written focus mainly on intradialytic hypotension after transfer from CRRT to IHD. One of these papers was done in our group led by William Beaubien-Souligny, who you've heard from during this meeting. What we did is look at patients at our hospital, St. Michael's Hospital in downtown Toronto, who transitioned from CRRT to intermittent therapies between 2007 and 2019. We identified 213 such patients. And some of the patients transitioned more than once, so there were 231 transitions in total that we studied. And again, the focus of our study was on intradialytic hypotension after transferring to intermittent therapy. And our goal was to identify risk factors associated with a post-transition intradialytic hypotension. Our population consisted of predominantly men who were in their mid-60s, baseline GFR around 46. The time on CRRT before transition was a median of 5 days, and about 25 hours elapsed between the end of CRRT and the beginning of intermittent hemodialysis. The patient characteristics at transition were actually quite interesting. Patients were still quite sick. Their SOFA score was on average 9, implying 2 or 3 organ systems that were affected. Many were still receiving vasopressors. Most were on mechanical ventilation. They had a moderate degree of fluid overload as well. But the problem was, how do you define intradialytic hypotension in the setting of AKI? There's a huge literature about this in the chronic dialysis world, but not a lot in the area of acute dialysis. So William came up with a bunch of potential definitions, and we looked at the relationship between each of these definitions and mortality to decide which was the most important one to choose for our study. And so to make a long story short, we definition 2A here, which comprised a discontinuation of intermittent therapy due to instability, the initiation or need to escalate vasopressors, or a nadir systolic blood pressure drop to below 90, or if the blood pressure was already below 90, a drop of 10 millimeters of mercury. That occurred in 50% of patients after they transitioned to IHD, and was associated with an adjusted mortality of about almost 3-fold compared to those who did not have intradialytic hypotension. So a very potent, in our view at least, a potent and relevant definition of intradialytic hypotension. So we want to know, what are the predictors? If you had someone on CRRT that you were thinking about moving to IHD, can you predict those who would not do well, at least hemodynamically, when they go to IHD? And we identified a few factors. Number one, patients with greater cumulative fluid balances, greater urine output, as you would expect, was inversely associated with intradialytic hypotension. But really, most importantly, was the persistent use of vasopressors. If a patient was still on a vasopressor at the time of transition from continuous to intermittent therapy, there was a 3-fold increase in the likelihood that he or she would develop intradialytic hypotension when they transitioned to IHD. Kind of makes sense, but nonetheless, we were, at least at our hospital, we were still transitioning patients on pressors. The overall model didn't discriminate that well, but again, I think at least gave us some insights with regards to some important predictors. The only other study that's looked at this was published last year, kind of similar to ours, 541 patients at a single center in South Korea who transitioned from CRRT to IHD between 2010 and 2020. They defined IDH, kind of similar to us, as the need to discontinue dialysis due to instability, plus a documented systolic blood pressure drop to less than 90, or a 30 millimeter mercury decline in the systolic blood pressure. And not surprisingly, IDH occurred in about 36% of their IHD sessions. Again, what were the predictors of intradialytic hypotension? Heart rate was an independent predictor. Urine output, again, like in our study, was inversely associated with intradialytic hypotension. The need for mechanical ventilation predicted intradialytic hypotension. And once again, just like in our study, almost a 2-fold higher likelihood of intradialytic hypotension if the patient was receiving a vasopressor at the time of transition. Another interesting finding from this study was that if a patient experienced intradialytic hypotension after transitioning to IHD, this was associated with protracted weaning from renal replacement therapy, again suggesting that the ischemia that we iatrogenically introduce to the patient when they dialyze with intermittent hemodialysis and drop their blood pressure can adversely affect their renal recovery. So, of course, these were the only two studies that I'm aware of that were published on this topic. They both had important limitations. They were both single-center studies. That makes them subject to local practices, and so generalizability may be an issue. And also, the focus was just on intradialytic hypotension. We didn't really look at any other parameters that we might consider relevant to good transitions. So hopefully the next steps will be to validate these risk factors in other cohorts and develop quality improvement initiatives that purposely avoid premature transitions from CRRT to IHD. So I'm going to conclude with a few words of, kind of in the absence of good evidence, what should be our approach to transitioning patients off of CRRT? So I think when we assess our patients every day, the first question to ask isn't whether they can transition to IHD, is the question, do they still need renal replacement therapy? This is something we sometimes forget about, and there's a whole other discussion for sure about what constitutes readiness to come off dialysis, what constitutes adequate endogenous kidney function. But if there's signs of improving urine output, and of course good metabolic control, and response to furosemide potentially as a means of controlling volume, it might be reasonable to stop all renal replacement therapy and as a trial and simply to watch the patient. But if there's no evidence of kidney recovery and the patient's percent fluid overload is say less than 5% and he or she has not been on pressors or inotropes for the last 12 hours, it might be reasonable to take them off CRRT and start them on IHD. And if not, simply to continue CRRT and only really be sure that they're really ready from a volume and vasoactive perspective before transitioning them to intermittent hemodialysis. Other things to consider after transition has already occurred. Have medications been appropriately adjusted to reflect the new treatment modality? Are treatment objectives being met? Just because you transition someone from CRRT to IHD doesn't mean they have to stay on IHD if IHD doesn't appear to be the appropriate thing for them. Have the sessions been tolerated from a hemodynamic perspective? If a patient keeps getting hypotension after each IHD session, maybe it's time to think about going back to CRRT. So those are important things to consider after transition. So in summary, I want to say that there is certainly a very important knowledge and evidence gap around RRT modality transitions. When considering transition from CRRT to IHD, it's crucial to anticipate whether the goals of renal replacement therapy can continue to be met after transition. Premature transition can have adverse hemodynamic consequences, which may in turn delay kidney recovery. And finally, the ability to achieve and maintain euvolemia with intermittent therapies requires careful consideration before transitioning patients. Thank you very much.
Thank you, Ron.